Good morning, everyone. My name is Kenan Demore. I'm an epidemiologist at the DC Department of Health, and we've been doing surveillance on overdoses and opioids and drug misuse since about 2014, 2015. So I'll start with the opioid problem in DC. What we've really noticed, it's a very different set of users. Our average user is much older than the US population, over 50 years old compared to about 35, 36. So we're dealing with people with a long history of drug use who've been using heroin since the 70s and the 80s. And what we've really seen is that patterns of drug use have not really changed. It's just that the supply has become a lot more dangerous. And we've seen a lot of concentration in certain neighborhoods, which I'll show later. So again, just to show what I previously said, over half of our people, almost half of our people are over 55. We see very few people under 35, actually. So that's good in that I don't think we're getting a lot of new users, just continued use. And it's pretty monolithic racially. Over 80% are Black, with the next race being white and very few Hispanics. So our surveillance really has been kind of three-legged. We've started with the fatal overdose surveillance, obviously, which we've seen go up with the deaths. That would be the medical examiner's office, Dr. Raza's shop. We have our death certificate as well, and we also have the hospital and EMS data that we use. And we are actually one of a few jurisdictions that does surveillance of the drug supply, and that we test samples at MPDCs or otherwise come to our attention to look at the overall drug supply. So our non-fatal really happens at the hospital level and using fire and EMS data. And dissemination is a big part of our strategy. There's no point in collecting all this information without sharing it with people who actually touch users and can affect the problem. So we really have a multi-agency work group. We've kind of split it into the emergency response with fire and EMS, police, and the hospitals, and the public safety cluster. We have testing with DFS and OCME. Then there's public health with harm reduction, the Department of Health, obviously, Department of Behavioral Health and Human Services. Then we have the criminal justice system, MPD again, corrections, probation and parole, and the courts. So I think the idea is that people who are actively using will touch a lot of these systems and touch a lot of city services. So all of these are opportunities to intervene or to get those people connected to services. So at the ED level, we have de-identified surveillance of every ED visit. So our definition is really a combination of a chief complaint and discharge diagnosis for an overdose. So we look at trends over time, but we can also look at people who have a history of opioid abuse in their records and whatever issues that they present with. So since our population is older, we see a lot of people with a history of abuse presenting with things like uncontrolled diabetes, hypertension, and things like that. So that's also something that makes us a little different from other jurisdictions. So this is really a word cloud of what we see. I mean, obviously, overdose, Narcan a lot, altered mental status. So really just a variety of complaints at the ER. So this is what we really try to do. We really try to look at when things are unusual. If you look at the red dots on the bottom, those are days when we had 10 people coming in with overdoses. So that's what we would define as an alert, 2 standard deviations over our running average. And that's when we really start to send out information to tell people that something might be going on. So this is really over the last few years. I mean, we've really maintained pretty steady. We've seen a rise since COVID, but there's definitely seasonality to it. Most of our overdoses tend to happen in the warmer months. People are outside a lot more. And we're maintaining the course for this year. As far as location, Ward 8 is where most of our overdoses are going to come from. We've seen Ward 2 creep up a lot. So it's Ward 2, Ward 8, Wards 5, and Ward 6, where we're probably seeing about 80% of the overdoses. So just to echo what I just said, average age of a person overdosing is 52. There's been a slight decline, and that's been driven by Ward 2. It's really a consistent 70-30 split, male-female. And again, Wards 5, 7, and 8, and now 2. So why Fems data? Fems is actually the best data source that we have because it includes XY coordinates. At the hospital, you can't tell where the person overdosed, but since we know where the ambulance went, we know exactly what neighborhood they overdosed in. So what we look for is a naloxone administration with documented improvement, or other evidence from the first responder that it was an overdose. The good thing is this has identifying information, name, date of birth, social, insurance information, so we can track people over time. So I will say we have a huge blind spot with our surveillance, because since we've basically flooded the city with naloxone, there are a lot of bystander reversals, and those are not reported to us. So I think we're always going to be missing a pretty large piece of the picture. So the typical EMS, I will say about a third of our people decline transport. I mean, it is recommended that everyone with an overdose have an examination from a medical professional, but a lot of our people just hop off the ambulance and we miss them. This population is slightly younger, it's 49 years of age, overwhelmingly African-American, but about a third of our overdoses are actually non-residents. We have a lot of Maryland and Virginia residents who overdose in the city. What we've also seen is a rise in people overdosing multiple times in a short period since 2020. I'll touch on that a little later. So one big tool we use is Odmap, which I would really advise you guys to sign up for. It's really real-time surveillance of every overdose. This is an API from our EMS, the patient care record. So whenever something that meets our definition of an overdose is, we plot it on the map. And this is something you could have live access to. What we really use it for is to see when things are unusual, and we call those spikes. Currently, our definition of a spike is 8 overdoses in the last 24-hour period. So when that happens, we'll send out an email like this: there have been 8 overdoses in the last 24 hours. We initiate the alert, and then we communicate within our partners to see how to deploy resources. Once the spike ends, I mean, we really look to examine what happened, how effective what we did was, and how we can improve in the future. So we have about 1 spike a week, to be honest with you. We just had one on Friday and Saturday. We had 10 overdoses on Friday, I believe. So that email went out. This is our spike response as to what we do when there's an alert. We really look for clustering. So we look for overdoses that are very close to each other in the same neighborhood, and really send people out there and the outreach teams. So this is the information how to sign up. I'm sure DCHA and DBH can share this after the call, but it's a very good tool, and there's a weekly report as well, so you can see what's going on. So as far as our repeat overdoses, we have a lot of people who are overdosing multiple times in a 12-month period. For 2021, we had 1 person overdose 8 times in that year, but we're seeing about 3 months in between overdoses. The shortest period actually was 1 day. We had 1 person overdose 2 times in the same day. So the biggest predictor is where it happens. A lot of our repeat overdoses are going to be in that Trinidad area and Ward 8, around the shelter and 2700 MLK, and Deanwood as well. So this is really just the counts. We're really averaging about 220 overdoses a month, which is pretty high. We're down historically, but I mean, we're really seeing about 7 overdoses a day on average. This is where it's happening. You see this school cluster downtown, Logan Circle and Shaw. The hottest area is going to be Trinidad, obviously, in Ward 5, and then Ward 8 as well. If we're tracking by neighborhoods, it's really going to be Trinidad, Logan Circle, and we've seen a lot more overdoses in the waterfront and Buzzard Point area, and Ward 7 and 8 as well. So really our goal is to link this data to prevention, to say when something unusual is going on, and we can push data for targeted interventions. If outreach teams or prevention workers are going to certain areas, tell them where to go. ESPERT is really the goal, to try to push people to treatment, but we can also apply this to multiple drugs. I will say this: our opioid overdoses are about 40% of our total drug overdoses. We have a lot of PCP, we have a lot of stimulant use, and those are things we also track. So we really look at events with these overdose clusters and spikes, but we can also look at people and decide who needs accurate interventions. And we really also evaluate how effective people in treatment are being. We can look and see if someone's engaged in treatment, if they're overdosing or not, and really try to push them in that direction. So the last thing I'll talk about is SUDORS. That's our unintentional drug overdose reporting system. So this is a collaboration between the Department of Health and the Chief Medical Examiner, where we really do a deep dive into all our fatal overdoses. So we abstract information from the death certificate, from the autopsy report, from the Department of Behavioral Health as far as treatment, and from the interview after death. So what we're seeing is that people present, about 30% of the deaths, most of the fatalities don't get naloxone. We're seeing a lot of people mostly are dying at night by themselves at home, but the toxicology is actually pretty concerning. We're looking at 95% of the fatal overdoses containing fentanyl. And that's it as far as my presentation. I'm welcome to take any questions now.
Thank you so much, Kenan. Really appreciate just kind of setting the stage for the symposium for the day, and we'll definitely get more into some of the details about what is in the substances that are being found in our next presentations from DFS and OCME. We did have a couple of questions come in the chat for you though, so let's take a second, answer those. Everyone, attendees, please feel free to send any questions to the Q&A for our presenters. So first, Kenan, can you report the agency code for Odmap again?
Sure, let me pull it out. It is WTG8Y37.
Okay, and maybe we can put that in the chat after the presentation as well, but thank you. Another question was with regard to the spike alerts, and I know this has been a topic of discussion a couple of times, but can you talk more about how you determined the threshold for a spike? And I think you talked about the number 8, so how you determine what you consider a spike that then needs to go to a broader audience.
So it's based on our running average over the past 90 days. So it's really 2 standard deviations over the past 90 days. But I will say this, I mean, 8 overdoses in a city our size is problematic. But I think what we're really moving towards is looking at a more granular level. So we really want to start issuing overdoses by ward or even the neighborhood level. So coming soon, we're going to start sending out overdose spike alerts that there have been, 3 overdoses in Ward 8 or something like that. And I think that's going to be more useful than just those spike alerts that are citywide.
Sure. So they're more directed and targeted. And I mean, I think that dissemination component is really critical, and not only that it gets to the providers, but of course to the community itself. And we had a question about kind of what that piece looks like. So do you know, is there any feedback from the stakeholders, like the residents of each ward, as to like, what do they receive the spike alerts, like the impact of this data? Does it reach them, and kind of at what point, or is it maybe more through the outreach?
So it's really more through outreach, but what we've seen is that our harm reduction partners, like HIPS, for example, is using their social media presence once there is a spike alert and sending out a blast, basically saying that there's something unusual going on, what neighborhoods it's happening, and those have been very useful. But you're right, there hasn't really been a systematic way. Our goal is really just to get the data to the providers, but I mean, I think we'd like to expand that to the community as a whole.
Yeah, absolutely. And of course you don't want to, I mean, there's a lot of thought that goes behind that as well. So another question, based on the findings that the overdoses are at night, what are your thoughts about outreach at night, or the kinds of activities that can happen at night? I guess
outreach was, initially.
Go ahead.
I think outreach was initially complicated by COVID, and I think, those face-to-face interactions pretty much shut down for a couple months after we got our bearing. So, I mean, the Department of Health doesn't really directly administer those services. That typically falls to the Department of Behavioral Health, But I do know that they're moving towards a 24/7 model, and they have the resources to really deploy.
Yeah, that is interesting data though about time of day and kind of how that changes potentially if that changes response.
So no, I would say, I mean, actually, most of our overdoses happen in the afternoon. I mean, we really see that peak from about 12 to 4. Then there's going to be a second peak between 10 to 12.
Great, thank you. Another question, do you partner with the Maryland and Virginia health departments to share data since you're seeing overdoses in DC from those states? And if so, what does that partnership look like?
We do share data. I mean, we're funded by the CDC to do a lot of similar things. And we have a lot of data sharing agreements in place just because of our geographical situation. We're bordered on all sides. The issue is someone overdosing here who's not our resident. I'm not going to say it's not our problem, but we can't pay for their services. I mean, they could potentially only seek private treatment here. We're exploring data sharing agreements with Maryland and Virginia, mostly Maryland. But the issue is it's a lot more of Maryland residents coming in than DC residents overdosing in Maryland. So it's not as much bang for our buck, basically.
And are you using CRISP at all for that?
Well, we're all pushing data into CRISP, but I mean, we don't really pull data out of CRISP for these purposes.
Okay. Interesting, yeah. Okay, we had another question about, I guess, policy. So we talked a little bit about how the data that's collected is used for dissemination and kind of getting back to the community. But I guess, what are your thoughts on how data is then used to inform policy and initiatives? Does it have an immediate impact, was the question.
I mean, I think as far as policy, I can't really say. I mean, I think it's been interesting in seeing the numbers going up. I think that makes policymakers want to be more aggressive in putting resources out. But I think the major utility is really just in informing deployment, saying you've had 30 overdoses in Trinidad in the last 7 days. You may want to send some providers out there or something like that. And I mean, I think it makes us more flexible as far as the harm reduction because we can see the problem getting worse. So I think it really necessitates more innovative solutions. So we're seeing things coming out like harm reduction vending machines in some of these neighborhoods that we can tell them where to place. So I really think that our numbers are really pushing creativity in terms of responding to the solution because we've basically flooded the city with naloxone and the numbers haven't gone down. And I think once DFS speaks and we see the toxicology and we see just how dangerous the supply is, I think we'll really grasp the scope of the problem.
I think that's a great transition. The next question was about nitazines, and I think we might hold that one for DFS as well. Dr. Rasso, just to set you up with a little bit of a pivot. But thank you so much, Kenan. Really appreciate your time and the data you shared with us today. And Dr. Rasso, I will turn it over to you.
Thank you.
Let me share. Okay. Oh, is that work? Is that working on your end?
Yep. We can see it. It's not in full screen. Is there like presenter mode?
Yeah, it jumped screens. I guess I need to share the other screen to do that. How's that?
Perfect.
All right. So thank you. I will hit on some of the, toxicology, the stuff we see in the decedents within the district. I think it actually will hit and kind of emphasize some of the points that Kenan had already hit on through their surveillance that we do see, within the decedent population. So briefly, this is my first time here, so thank you for having me. So I'll hit just very quickly on our department. Obviously, we are controlled by the Office of the Chief Medical Examiner here within the district. We do primarily perform the postmortem casework for the district through the ME's office, as well as supporting human performance testing, whether that be DUIs or drug-facilitated sexual assaults. So I'll show some of that data. I know it's not the gearhead of this is opioids, but it kind of gives a good picture of the overall kind of drug use that we see that comes through our agency. So we're fairly small. We have 7 toxicologists at the moment, but we're onboarding 2 more, which is great. We have multiple programs within our department. We do support the breath alcohol testing for all of the district. And then we have method development, which utilizes the different methods that we would use for our testing, and of course, quality control, as well as a laboratory assistant, laboratory technical coordinator, and the chief, and as well as myself here within the department. Okay, so we'll jump into the stats. That's more interesting. I'm gonna show some stats from 2020 because it's the last year we have a full picture of the whole year. 2021 is looking fairly the same. So I'm just using these as an example to show the big picture, and then I'll show the specific 2021 updates, though they're fairly the same from year to year. So post-mortem wise, in 2020, we saw about a little over 1,600 cases come through in comparison with DUIs around a little under 400 and sexual assaults around 60 or so. So we had a total of a little over 2,000 cases come through. That was an increase of a little over 200 from 2019, and 2021 probably be closer to 2,500-ish for this year. So we're still continuing to increase through our agency. So most prevalent, again, for DUI, not as geared toward this, but it's nice to see the different type of drugs that are out there that may be, they might contribute to a decedent in the future. So we'll see a good kind of trend, if you will, with ethanol, of course, PCP, as Kenan alluded to, we have a lot of PCP use. Cocaine and fentanyl, of course, we will see very continuously, as we know, being fairly problematic. DFSA cases are a little bit different, but you still see the cocaine use is really out there. And marijuana, of course, being recreationally legal here in the district, we see that pop up quite a bit. But more importantly, the ones we're really looking at are the postmortem cases and the decedents. So as we can see here, to no surprise, fentanyl is the largest number of positivities that we see through our cases here within the decedents, followed by ethanol and 4-MPP, which typically you're going to see with fentanyl, as it's most commonly an illicit byproduct. It can be a minor metabolite, but that's in very low amounts. Most commonly, we see that as an illicit indicator of that fentanyl. And as we've said, marijuana is a highly used drug component here, and cocaine kind of being on the rise, at least at the moment, which I'll hit on in a little bit down the line. So those are our postmortem cases. And this is all postmortem. We're not specifically at the ODs yet, but it gives a little bit of a snapshot. Something that's kind of interesting, and it kind of really further emphasizes the fentanyl kind of prevalence. So here's our top 10 drugs we see in postmortem cases, and the most common second drug on board, if you see. And so you can kind of see it's a very strong, that even with all other drug uses, fentanyl is almost the most common secondary polysubstance that is on board with the user. So it's just a really strong emphasis of the prevalence of fentanyl, even when possibly using other drugs of abuse out there. Okay, so that's just a good snapshot, but we'll move into some more of the actual overdoses. So again, 2020 is the last one we have a total for 521. Fentanyl, 4-MPP, as I said, cocaine definitely on the rise, and what we're seeing coming through. I'll hit a little bit on the naloxone that Kenan hit on a little bit. You see it's a much smaller percentage than you see, say, the cases that have fentanyl up by 75 versus 25. That's a big discrepancy. And we'll see that here again in a little bit. In 2020, the one thing that we did see acetyl fentanyl back then, we don't really see that much more in our populations anymore, as there's been a little bit of a rise of a different analog, which is fluorofentanyl, that I'll touch on as well. So this would be the age and drug kind of distribution that we see among our top 10s. And as Ken pointed out, we see a lot more of the higher numbers in the older population within the district. So that's definitely, a good snapshot of that demographics, and that at least has been consistent since I've been here with the OCME. But there's definitely a big increase within that older population. This would just be the race in the drug. Again, the distribution has been mentioned. It's vast majority Black, followed by white, Hispanic, and that's pretty much regardless of drug of abuse down the line here through the distribution. Okay. All right, so that's just 2020 for a snapshot through 2021. So we're up to over 1,800 opioid-related fatalities since 2016, when they've started tracking these as the opioid crisis really started to increase. Here's just a tracking of month to month through all of those years. We really saw a big jump from 2019 to 2020, went up by about like 130-ish through the year. 2021 has been pretty much on par with 2020 thus far. It looks like so far only 11 different, so about the same. So nothing has unfortunately dropped off in the opioid-related fatalities through 2021, but that is where we're at thus far. So as we'll see, there was a rise and fall, but not the fall of fentanyl, as we're all aware of. Here is from 2016 through 2021. You'll see this black line is the rise of fentanyl. That has really, really increased, and at least to this point have not really shown any signs of declining. I did ask our statistician to pull the naloxone numbers. And so out of this 422 opioid related deaths, only 144 were actually given naloxone. Unfortunately, it obviously didn't work in these particular decedents. As Kenan kind of pointed out, that doesn't capture how many the naloxone may have saved. But at a minimum, that's a big discrepancy between people that weren't even given it for whatever reason, whether being alone or someone didn't have it. But that's still that's a big difference between decedents and the naloxone being available. This is just a percentage-wise because it's easy to see how consistent it has been, well over 90% for the last few years. And as I mentioned, we don't really see the acetyl fentanyls pop up too much on our end, but we've had 66 cases of the fluorofentanyl within our decedent population in 2021, which was a big increase from previous years. That's the main analog we're seeing at the moment. Of course, those are always kind of changing as drug supplies change and different kind of compounds hit the streets. But that is the current fentanyl analog that we're seeing within our decedent population. Okay, here we go. So we do see some prescription opioids within the overdoses. So here are those throughout the years. Oxycodone had typically been fairly consistent. It stayed about the same. Methadone is still the highest. We have seen an increase in buprenorphine, which could be from an increased use of treatment facilities using buprenorphine during methadone, as it has a lower addiction kind of, than methadone. However, it has a lower ceiling of effect than methadone does, so it can be harder to get the right dosage. So that sometimes you may see users, even though they're on their bupe treatment, still go out and seek something else to get the right kind of feeling that they're looking for. But we have seen an increase in that, and that's again possibly from the treatment facilities around the district. The demographics, I won't spend too much time on it as Kenan hit on it, and I'm pretty much just saying it's about the same. We see 74% between 40 and 60, the older population within a district are the ones overdosing, as well as the majority of those being males, around a little over 70%, and that's stayed fairly consistent throughout the last 5 years or so. As well as race, as we mentioned, the Black population is the vast majority compared to the other ethnicities, with white being the second one behind those at a much smaller amount. And about 84% of the decedents in 2021 were African American. By location, from what we've seen, Ward 8, Ward 7 still are the highest. We have seen an increase in Ward 2 this year. Ward 3 has a slight increase, as well as Ward 4, not by much, but there are some increases within those wards. But 5, 7, and 8 have continued to be the highest within the population here at OCME. Through some of the working group conversations, we kind of were wondering about physical location of where they are, maybe hinting toward why they haven't gotten naloxone, or what are their circumstances. So in 2021, 82% of these were actually within a residence, and 73% of them were in their own residence. So we went back to compare this to 2019, where we saw 71% just within a decedent's residence, and 2021, 73%. The reason we kind of checked this was mostly because of the pandemic. If everyone was in their house, they were by themselves, was that leading to more of that physical location of overdoses and lack of maybe having someone around or a bystander to try to administer naloxone. Though interestingly, even pre-pandemic, it's roughly the same. So it's stayed fairly consistent that it's just mostly a lot of users within their own household, typically alone, which could account for why we see that discrepancy between overdose numbers and naloxone administrations of those overdose decedents. So this effect of cocaine has really kind of hit this year. Speedballing was obviously very popular in previous decades, if you will. We see here opioid only has dropped a good bit through 2021, with that cocaine use really popping up, and then of course the mixture of those popping up, as we see users are out there a lot of times thinking the cocaine stimulant is going to counteract the effects of your opioids, and that's not entirely true. It may mask some of the feelings of it and the down depressant much, so you might stay a bit more alert, but the actual effects on the body and pharmacology on your respiratory systems are not being counteracted, so you see a lot of overdoses from that. So we have seen that rise in cocaine through 2021. So yeah, overall, unfortunately, opioid fatalities haven't seemed to slow down this year. We're stayed pretty on par from 2020. Fentanyl is still the largest factor. We even see that within the human performance population. As I've mentioned, fluorofentanyl is the current majority fentanyl analog we see for now. I'm sure that's typically an evolving door of different analogs that pop in and out of the population. And again, with cocaine is on the increase right now. That may hold steady, that may drop, but at the moment it seems like there's an increase of cocaine mixtures with the fentanyl and or heroin out there on the streets. Demographics have stayed fairly consistent, along with the jurisdictions of where they're happening. Though as I mentioned, we've seen a slight increase in Ward 7, 2, and 3, and 4 a little bit as well. And the majority of these are happening within a decedent's household, and they are typically alone. Again, which may be fueling that discrepancy of naloxone administration versus our decedents. But that is a little bit of the data we see on the back end here at OCME, but I'm happy to take any questions anyone may have.
Thank you so much, Dr. Rosso. And we do have several questions that have come in. The first one is, could you please comment on the naloxone and buprenorphine? I might actually ask those separately. Can you comment on the naloxone piece specifically that you're finding in the data? And then separately, I know you spoke a little bit to the buprenorphine potentially as being due to an increase in treatment, but we certainly don't want to, you know, imply that we shouldn't be using the form of treatment. So kind of how would you advise to use those data effectively?
Right. Yeah. So I would agree. So for the naloxone part, I guess they didn't ask specifically which part of the naloxone about it. But what
Perhaps
we do.
since you're, I'm sorry, go ahead.
Nope. You're okay. I mean, we do see it, of course. We find it in a lot of decedents. They were administered it. There are times where maybe it was administered, you know, kind of post passing, if you will, as an attempt, and it was too late. It's obviously possible that it was given and it just, you know, dosage is always very important, and maybe it wasn't enough. So that's, of course, by no means, you know, a reason not to use it. But there are a large amount of decedents that we see that don't have it. You know, that's where you see only like 35% of them were actually given naloxone. So, you know, there's no way to know if, you know, the other 70% would have been safe, you know, but of course that's something that would be important, and you would like all of them to have that. And, you know, I can't speak on the actual reasonings why they're not there or why they haven't been given. That's where the locational data that they're typically home alone may be a driving force for that, but I obviously can't speak on that for sure. As for the buprenorphine, again, it's not a reason not to use it. Just like methadone, they are useful in, you know, treating the users, you know, to get them off, you know, in a safer manner. What with buprenorphine versus the methadone is it does have a lower effectual ceiling, right? The methadone is more potent, so it just can be a little bit more difficult to get them on the right dosage to feel, you know, enough of the effect that they're not going to be going out on the streets looking for that secondary high, if you will. So it's just a little bit more difficult for the treatments to get it, you know, on par. And so sometimes you could see, you know, if it's not correct, they might go out for the second, you know, an additional high, if you will. I mean, they could do that with methadone as well. So that it's not that that's a deterrent. It's just something to take into account for the treatment. You gotta, you know, it's difficult at times to get the right dosage so that they're leveled out appropriately, that they don't go out looking for something else. That's all. But definitely, you know, definitely not a deterrent. If it came off like that, not what I meant.
Certainly, yeah, and I think there's a role there for in hospitals. We have our peer recovery coaches who have talked a lot about sometimes in those conversations with patients who have said, you know, I don't want to try buprenorphine. I've tried it, you know, but it wasn't necessarily something that was being prescribed and clinically managed. And so to be able to have a conversation to say it can work, and, you know, maybe it worked for me, that kind of thing, that shows that when it is being prescribed in the right way, that it can really be helpful. But certainly that when it's not, it can also be harmful, and that's important for someone who has been in that position before to be able to speak to in a way that builds trust, to really help people move towards evidence-based treatment. So thank you for commenting on that.
Yep.
A couple other questions. Is this summary correct? Older male at home with a fentanyl overdose is the most common clinical picture seen in an overdose cardiac arrest.
Oh, that's a loaded question.
Older male at home, fentanyl.
All I can say that they're, you know, in what we see, a lot of, you know, the larger, I guess statistically, the most amount we do see are older males at home, and fentanyl is the most common drug compound that we do see within the overdoses, if that's
okay. And specifically when you're talking about fentanyl,
Mhm.
what's the rate at which you're seeing fentanyl like in its pure form versus fentanyl in combination with other drugs?
Oh, I definitely don't. I don't have that number offhand, but I would say most commonly there are. There's a good. I don't want to say majority, but there's a lot of times where there's only fentanyl. Like I said, when we see other drugs of abuse, more commonly you will still see fentanyl, but we will see fentanyl by itself a lot. Um, so we don't see as much, maybe heroin and fentanyl as much as we kind of just see fentanyl in that aspect. Or now, as I've mentioned, now we see a lot more of the fentanyl and the cocaine kind of uprising. But we would still see a lot more fentanyl alone than cocaine alone, or fentanyl alone than heroin alone, or methamphetamine, anything like that alone. I don't want to misspeak in statistics, but it would be definitely of the drugs, probably the most common to still also be alone.
Okay. Yeah, and the commenter had just noted that people who use cocaine may not actually carry naloxone or be prepared for an overdose, if that's the case. So it might affect, messaging and dissemination of Narcan as well.
Yeah, the whole speedballing issue, I think, is a big misnomer in uses. Again, where people think because you're taking a depressant and a stimulant, they're gonna kind of counteract each other, when really they kind of can exacerbate each one in their own way. So that there's a lot of misnomers and kind of dissemination of education on those kind of aspects, along with, as you mentioned there, with the Narcan not going to affect the cocaine use.
Sure, that makes sense. And sticking with fentanyl, we had a question: with the prevalence of fentanyl permeating the entire drug supply these days, will we eventually see fentanyl testing frequency going up, whether that be in hospitals, treatment centers, et cetera? I keep hearing it's too expensive to test for individually. So I guess the question is, obviously it gets to you when at the point of someone who has died. So kind of where do you see the role of other agencies that may be able to test in supporting kind of the surveillance here?
I would say there's definitely an avenue to do it. As we've heard of fentanyl strips coming out, a lot of hospitals that may be seeing these users, they still do typically, brief urine drug screens, things of that nature. And as we've seen, we do see different fentanyl analogs pop up from time to time. As I've mentioned, there was acetalfent was kind of more prevalent a little while ago, fluorofen a little bit now. But even so, you will almost, at least for us, we will almost never see an analog without fentanyl there. And so you can drive a screening test fentanyl specific, and you can still capture a lot of those within there. And there's definitely a way to do that through something like the fentanyl strips, quick immunoassay screens, like the hospitals typically have, urine screens, and you can still gear them toward the specific fentanyl drug, because again, you're not really going to see, at least at the moment, something else without the fentanyl. The fentanyl is typically still there. So if you gear towards that, it's definitely, within, testing scopes to look for that. Granted, it's harder to get them out, say, on the streets. So people are going to test what they have. It's still going to be after the fact, whether it's an overdose that they didn't pass and they're in the hospital, or EMS, something like that. I think that the bigger hurdle would be to get it beforehand, whether they fatally overdose or non-fatally overdose. It's getting it and that testing done kind of before use versus after.
Sure. Yeah, and I know there are some national examples, group out in San Diego that's been using, they added fentanyl to their kind of typical urine drug panel that is found in a hospital. And that's kind of been helpful from a surveillance perspective at the ED level
Mhm.
as well. I think the question then becomes, if fentanyl is in everything and that's the given, then what else do we need to be looking for that we might not be seeing?
Mhm.
So if I may kind of bring us back to that transition question,
Mhm.
can you talk at all about nitazines? I didn't see that in your slides, but have you seen that in the data at all?
So on our end, we have not seen any. Though I do have to caveat it a little bit because not every single case would get the screen that would capture a nitazene, if that makes sense. We're driven by the medical examiners and the stakeholders, regardless of who the stakeholders, what testing they would like. So, there's always a caveat of, did we just not test for it? And maybe it would have been there. That's always a possibility, unfortunately, because we don't have the capacity to test every single thing for every single thing. However, in all of the cases that we do test, we have not seen any in our population to date.
Sure, that makes sense. And certainly something to keep, I think a question that will be important to keep asking, not only for that, but for others.
Yeah, like I'm sure Alex will hit on it, that they've seen some, and we typically do lag behind them, 6 or 7 months or so. So since they've kind of started to see them pop up, I would say, it's a fair assumption that we may see it pop up, in the coming months as we do lag behind them. Hopefully not, but that's typically how it runs.
Sure. We do have a couple other questions about fentanyl and then some more about surveillance. This is a great audience engagement, so thank you, everyone. So this one, how can I back to what you had talked about a little bit earlier about fentanyl test strips, how can testing strips play more of a role for the people who use at home, and what kind of messaging do you feel would be appropriate for an at-home testing campaign?
That's tough. So the fentanyl test strips can definitely be a good, at least initial starter, right? The problem is, it may tell you fentanyl is there, but it's not necessarily going to say how much. And with something as potent as fentanyl, that's kind of the kicker, if you will. It doesn't take much to go from, call it a therapeutic high, even though it's not therapeutic, but I don't even want to say safe high, but a high versus an overdose. That line is very thin, so if the users are going to be using these fentanyl strips, and, it can be appropriated out to, like, make sure it's cocaine versus fentanyl, or make sure it's heroin versus fentanyl, but that's also kind of a slippery slope to then, encourage them to use another drug, right? That's always kind of the battle, because you're trying to find safe ways to help them. But I guess to get back, the fentanyl strips are definitely a helpful, source for users, but I think it would be important to, as always, education, especially for the drug users, I think is very important, to know. Just because your strip says it's there, it's still very important to understand the amount and the dosage, especially with something this potent, because it's a very fine line.
Sure. And then it's ultimately, I think there's a degree of promoting caution that is in the messaging, and it might not necessarily be like encouraging someone to use any drug, but to
Of course.
use caution. So that's a good point.
Of course.
Sticking with fentanyl, this is a little bit more of a clinical question, but with the rise of fentanyl, is it your understanding that the common and in many cases maximum recommended dose by certain states of 16 milligrams of Suboxone is not sufficient to help patients receiving MAT for opioid use disorder? Can you speak at all to dosage?
I don't know if I can speak to exact dosages between them. I think, again, from our perspective, it's definitely, a lot of data can be pulled, a lot of testing can be done with the fentanyls and the potency versus the Suboxones and things of that nature.
Yeah.
So I can't speak on specific dosages, but it's definitely important to, the more important thing is to get the right balance. Because again, it's that potency is, is the big difference. You could take some Suboxone, right? And it may not be enough depending on what dosage you took. So it still goes back to, as you're mentioning, that caution and understanding and, doing, being as safe as possible and using that, appropriately, for the users out there.
Certainly, and something we talk about a lot with the hospital teams working on their like buprenorphine protocols is we want to make sure that buprenorphine can be available for as many people as it's who are clinically eligible and motivated for treatment and things like that, and that it's not only the addiction medicine docs who are the ones doing it, which might be they might be the ones who are best equipped to deal with specific dosage requirements and microdosing and things like that. But if we're making, a protocol that can be used by a lot of different providers to support people with opioid use disorder, kind of setting some kind of standard that can help a little bit is important.
Yeah, for sure. And it's definitely difficult with, opioids specifically with, tolerance is a real factor with these. So it's very hard to set a flat line with, say, your buprenorphines or treatments like, hey, we're going to give everybody this dosage, but everybody has such a different tolerance level that what each individual is going to need is going to be very individualized, which goes back to, like I said, you can see users on a bup treatment, but maybe it's not the appropriate levels, and it'll be very, very individualized because you don't know how long they've used it, what their tolerance levels are at. There's just a lot, there's a lot of variables to take into account, but, there are definitely things that can, that are helpful and should be done.
Right. And it might be started at a standardized dose, but then again, kind of thinking from the hospital perspective, it's our partnership with all of the community providers on the line is so critical to help with those dose adjustments after someone leaves our doors. So, okay, shifting to some questions we got just about surveillance kind of more generally. Is there a reason, or can you speak more to the spikes that you're seeing in wards 7, 2, and 3?
Oh, I don't think I can speak on that.
That's a big question.
That's, we don't see, unfortunately, in our end, we don't see as much of the, the surveillance as like, Kenan does a lot of those, or Alex when they have the syringe projects and things like that. We just kind of get the data of where they were. So I definitely can't speak on why there may be different spikes in those wards specifically. Me personally, I don't want to misspeak or anything on that.
Certainly, yeah, that's a fair question, fair answer. Another question, what proportion of the overdose deaths that you've seen are associated with injecting versus pills versus other mode? Do you get any data on kind of mode of use?
We don't typically. I could probably get that added into future presentations because our statistician, she gets all of the information after the fact, and she gets the case circumstances and all of that nature that we're not privy to. All we're really getting is the testing side of it. We're just one cog in the machine, if you will. But that is an interesting point because especially with the rise in fake pills and things of that nature, that definitely could be something we could try to put together for future presentations and things of that nature to try to link that for sure. That's a good question.
Yeah, certainly. And I think kind of also to that, it's about like what's reported versus what are we actually seeing. And another person had asked, they've heard reports that youth are overdosing at a higher rate. Does your data support that? Do you have data that or refute that, I suppose?
I would say, we have, where my age? So in 2021, under 20, we had 9 versus 2020, under the age of 20 was 3. So I would say that is definitely a significant increase. Luckily, those are still fairly low numbers, but that is from 3 to 9, I would say is definitely a fairly significant jump within a year.
Sorry, yeah, I agree, and something that we should keep an eye on, and also maybe to see in Alex's data as well, if you have anything on age, Alex. Thanks for your patience. Just a couple more. You had mentioned about overdosing in homes. And I see kind of in the chat, people tend to overdose close to home. Certainly we know that would impact the usability and whether naloxone is able to support an overdose reversal. So I guess, what are your thoughts on that? Do you have any kind of feedback on what kinds of messaging might be important then for people if we're seeing higher overdose rates in homes?
Yeah,
data.
Yeah, I mean, I think, you know, it still goes back to the same message of cautioning and using safely or as safe as you can. If you're gonna make the choice to do this, these are the precautions that you should take, right? It's all how that can be phrased and messaged, you know, down to don't do this alone, you know, almost how, you know, it's very, you know, out there. If you're going to go out drinking, you have your DD with you, you have someone with you, right? It's kind of this, you know, you could maybe, you know, message things along the same lines of, you know, making sure someone's with you, not being sitting at home alone. You know, I think that might take more to the people that are out and about using versus if you're just a long-time user, you're at home on a weekend night and you're, you know, choosing to use, it's hard to, you know, break that mold and have them have someone else with them. But again, it's different cautionary, you know, information that can be out there that may or may not take and, you know, might help for them being, you know, in those types of, you know, areas.
Yeah, for sure. And, you know, maybe as we're talking, you know, all about Narcan and getting that into people's hands, to emphasize that piece as well, to not use alone, makes sense. So I will do one more here and then we'll go to Alex, and then I'll take the rest of the questions to kind of the group to speak to at the end, perhaps. So of the men between 50 and 65, is it possible to see how much or how long the individual had been using narcotics? Does toxicology show that?
Yes and no. Toxicology, not necessarily. The pathologists, through their autopsies, could see, you know, some, you know, weathering, you know, if, you know, we're talking about respiratory depressants, you know, if they've been using all of their lives, you know, you can see some effects within, you know, within the lungs, but that's going to be on the pathologist side more so than the toxicology. Toxicology, the only thing you may see is a higher dose, but again, it's hard to say, is it a higher dose because they've been a long time user and their tolerance was high, or did someone just have a one-time up, right? We can't distinguish that just from what we see. Unfortunately, you know, we can only see what was there that time. You know, we can't, that doesn't give much information about, you know, chronic or acute, you know, use it, you know, in that instance.
Yeah, that makes sense. It's a fair amount of, I guess, conjecture from the end point, but I do appreciate your willingness to speak to all of this. I do want to just quickly, before we go to Alex, Kenan, I saw you come off mute for a second. Was there anything you wanted to speak to with regard to the DC health surveillance?
No, I was going to say, as far as the overdoses moving, I mean, we see the hotspots tend to move as the supply changes. And I guess that's where public safety and law enforcement are important, because people are overdosing pretty close to where they buy. So when we see a dealer getting arrested, people have to buy from someone new who they may not trust or know that well, or it could be someone inexperienced who mixed the drugs in an unsafe way. So I think a lot of, as those overdoses and hotspots are moving, that's why we're seeing, you know, more people from Ward 2 or Ward 5 overdosing, because there's just more drugs being sold there.
But it's more on the supply side. Great. Thank you so much, Kenan, and thanks, Dr. Rosso. So lastly, I will pass it to Alex Evans from DFS. Thank you.
Hey, I'm just trying to share my screen real quick. All right, can you see everything?
Yep, we can see you. Your
Okay.
screen.
So my name is Alexandra Evans. I'm a chemist here with the DC Department of Forensic Sciences. And I'm just going to go over some of the highlights that we've had recently, but to give you a little bit of background of who we are and what we do here. We perform drugs surveillance for Washington, D.C., in an effort to better characterize the district's drug supply. And so part of this program is that we look at 4 different stages of the drug pipeline. First, we analyze seized drugs directly from the local drug supply. We also analyze syringes from needle exchange programs to look at IV drug use. And one of our newest additions is analyzing urine specimens through clinical monitoring. And right now we're looking at specimens from Department of Corrections. And lastly, we do analyze syringes that are associated with death investigations. This means that they're collected at death investigation scenes, either on the person or in the environment proximity. So the types of exhibits that we get, so for the drug supply for seized drugs, we get powders, we get pills, we get sometimes drug paraphernalia, sometimes drug residue. For syringes from the needle exchange program, we just receive those syringes. And for the clinical specimens, we analyze urine specimens from the Department of Corrections. And then, as I said, for death investigations, we are analyzing syringes from death investigations, but on some occasion we have analyzed residues that are nearby or half ingested pills. So the big topic is the synthetic opioids. As Dr. Razzo and Kenan already said, fentanyl has been pretty pervasive in the district drug supply. How we see it in our lab is that we see it in all forms. We see it in powders, we see it in syringes, we see it as solids, we also see it in pills, primarily counterfeit opioid pills, which I'm going to talk about shortly. But other synthetic opioids that we've seen are isotoniazine, which we've seen only twice so far. We saw it once in September of 2021 and once in October of 2021. So we have not seen it since then, but one of the caveats is that we cannot analyze everything that is in the district. Unfortunately, I wish we could, that would be great, but we aren't analyzing absolutely everything. So there is a chance that it is out there in other forms that we just haven't seen yet. So in our seized drugs, specifically, we have seen this fentanyl increase starting in 2018. And just looking up until last year, we primarily see fentanyl without heroin. It's pretty much taken over. I will say we now very rarely see heroin by itself. And we see fentanyl in combination with pretty much everything: cocaine, methamphetamine, ketamine, methadone, buprenorphine. It's kind of touched on every facet of the drug supply. So one of the issues that I want to talk about is counterfeit pills. So in 2021, the DEA released a report saying that they had confiscated 9.5 million fake tablets. This is something that is definitely increasing in popularity, especially in DC. And what we have found in our lab is that we are primarily receiving what appears to be genuine oxycodone pills, but is in fact fentanyl pills. So just to kind of give you an illustration of this, the photos on the top row, those are manufacturer photos from drugs.com. These are what the oxycodone pills are supposed to look like. And this bottom row is photographs from our lab of the counterfeit pills that we've actually received and that we chemically determined to contain fentanyl and not oxycodone. So the imprints are pretty good. The pill presses that they're using are actually quite good. For us as chemists, we can visually see some nuances of, colors being slightly off or imprints being slightly off because we handle these on a daily basis. But for a user, it's concerning because they're not able to detect these subtle nuances that we know. And the only way for a user to know is if they actually got it chemically analyzed. So it is of a huge concern. Now, opioid pills, those are not the only counterfeits we've seen in the lab. We have seen counterfeit benzodiazepines, although we see them a lot less frequently. And of all of the counterfeit benzos that we've seen, they have all been suspected Xanax, or alprazolam is what it's called. And what we've detected instead of alprazolam is actually atizolam and flualprazolam. So these are both novel benzodiazepines that are not approved for human use. So there is dangers with users taking them, especially when clandestine chemists, what they're doing is they pretty much have a low level knowledge of interactions in the body. They have a low level knowledge of concentrations that are user friendly, I'll say. So when users take counterfeit pills, they're often getting them in much higher concentrations than intended for a user with unknown side effects for users, especially in combinations with everything else. So we did a deep dive of our data and we found that, in 2021, we had seen this massive increase in counterfeit opioid pills, that when we received pills in our lab, now it is more frequent to have it be a counterfeit than it is a genuine pill. And of those pills, the most prominent counterfeit pill that we receive is the 30M imprint oxycodone, which is a 30 milligram oxycodone pill. This has been pretty common in DC. So one of our other surveillance efforts is we do analyze syringes from needle exchange programs. We started this in September of 2020, and right now we're working with 4 different local needle exchange programs, which is great. And it allows us to get some real-time drug user data because we get syringes, they're delivered to us on a weekly basis. We can analyze them within a few days. And we can get results out very quickly. This is actually how we were able to detect isodonidazine in the drug supply, was through needle exchange syringes. So, we do see it as a great effort to surveil for emerging threats in the district. And so far, we've analyzed 2,585 syringes in total. Most of those actually being opioids, and most of those opioids actually being synthetic opioids. So when we talk about synthetic opioids, yes, we are talking about fentanyl, but we're also talking about every other synthetic opioid, methadone, buprenorphine, tramadol, and nitazines, among others. But I will say fentanyl has been the highest detected substance in all of the syringe exchange needles. We do detect a fair amount of cocaine, as well as methamphetamine, and every now and then benzodiazepines and hallucinogens, ketamine, etc. So this is just to emphasize the point that fentanyl is pervasive in the drug supply. We do see fentanyl primarily without heroin, and we do see fentanyl with cocaine on a regular basis. Now, one limitation of the syringe exchange needles is that we're not able to determine whether a syringe has been reused by other people, if the drugs put in the syringe were together at the beginning, or if someone did back-to-back injections. That's not something that we can determine. We just can tell you that they were found in the same syringe. In fact, out of all of the cocaine containing syringes, about 63% of them also contained fentanyl. So what I can tell you is that in our seized drug supply, we do not very often, I would say almost very rarely, see fentanyl and cocaine in a powder mixture together, which leads us to believe that it is an intentional decision made by an IV drug user to mix cocaine and fentanyl. So we did an interesting study, we participated in an interesting study last year with the Center for Forensic Science Research and Education, and they did a survey of toxic adulterants nationwide. They got 9 states to participate, and we were happy to be one of them. We actually donated 91 samples to their efforts, and it was determined that Washington, D.C. had the highest amounts of toxic adulterants. So what we mean by toxic adulterant is it's a substance that's pharmacologically active on the central nervous system, but it may not be controlled. It's substances like Xylazine or Tizolam. They're still harmful to the user, but they're typically added into the drug supply to increase profit margin or increase weight of the drug. So, you know, when we saw that, we weren't that surprised, seeing as we've analyzed syringes from needle exchange programs, and we see a lot of adulterants mixed in with fentanyl. We see a lot of different things. We see levamisole, we see phenacetin, we see xylazine, atizolam. There's a lot going on in these mixtures, and all of these, you know, can be detrimental to the user. So just going on to explain a little bit more about xylazine. So like I said, it's not approved for human use in the US. It's not FDA approved. The first time that we actually saw it in our lab was in August of 2018, and this was in a death investigation. We found it on residue on a spoon that also contained fentanyl, ketamine, cocaine, and methamphetamine. There's a lot of associated dangers with xylazine use, including skin necrosis, as you can see from the photo on the right. Typically what happens is the user will re-inject at those sites because they're receiving pain there, which causes the skin necrosis. It is also a respiratory depressant, so it increases this risk of overdose. But we do see it very, very regularly in the syringe exchange program. As you can see, it's the third most common active adulterant in the syringe exchange, right behind diphenhydramine, which you'll know is Benadryl. The most common substance we see is caffeine. Obviously, it's just added as a stimulant, increase effects for the user. So what we have been able to determine from xylazine is it is a toxic adulterant, but it's not preferentially adulterating any one drug. It seems to be evenly divided between fentanyl, heroin, and cocaine, and it's adulterating all of them. So what we suspect is that it's just an easy adulterant for drug dealers to use to mix in with everything. So we do death investigation syringes. The biggest takeaway from here is that we do see slightly more levels of cocaine in death investigation syringes, whereas we see slightly more levels of methamphetamine in the syringe exchange. But one caveat of this is that we don't receive a lot of syringes from death investigations. You know, we don't receive a lot of those. So Dr. Razzo has a lot more data on death investigations. So for toxicology, right now we are doing a 14-drug FDA panel using the Alinity-C, and this has allowed us to take a look at urine specimens from Department of Corrections. And the clinical specimens, they are from a combination of intake and people who've been in the facility for a few days, but the highest detected substance is buprenorphine. As has already been discussed, you know, this is a commonly prescribed opioid to treat opioid use disorder. I think the most interesting thing, though, is that we see fentanyl most often in combination with buprenorphine in these toxicological samples. And the reason for this, as Dr. Razzo said, is that, you know, it is hard to get the dosing right. So what we're seeing is users who are still using fentanyl as they try to get better dosaging for this medication. And that is all I've got.
Thank you so much, Alex. Really appreciate that framing and, of course, all the data. We have a couple of questions for you, and then we'll bring back our other panelists as well to just kind of finish us out with a discussion of where we've been and where we might be looking. So, Alex, for you, can we test syringes for bloodborne diseases? Can you comment on the utility, and it might open new funding streams?
That's a great question. Currently, we do not have the capacity to test for HIV within the syringes. However, there are discussions on that topic. So yes, this is this is a direction we would very much like to head into, but I don't have any information other than that so far.
Thank you. And we'll start with you, and then again, Dr. Rosso or Kenan, if you'd like to comment, but specifically for the syringes, are there other, I know we've been working, trying to see if there's opportunity for hospitals to support the surveillance that DFS does, just from an epidemiology perspective. Are there other data sources that you think in a dream world you'd like, what other data sources would you like to have, I think, to kind of help paint a more complete picture? We'll start with you and then go to Dr. Rosso and Kenan.
Yeah, I think the biggest thing is I would like to start getting into the non-fatal overdose data from hospitals, urine and blood specimens, as soon as time and funding allows for that.
And we have, I won't go too much into it, but we have talked a little bit with our lab teams about that. And I think it's definitely something that the hospitals are interested in. If I can say that, I think there's just some logistical concerns, that we're all running into from a staffing and supply chain, frankly, perspective. But I think that from what I've understood, that this would be an area that would be really helpful. And obviously the data is beneficial in a bidirectional way. So would love to, we will certainly continue to work with you to move that forward. Dr. Rosso, any other data sources in a perfect world you'd like to have?
I would say in a perfect world, you want all of the information, especially for us on the end of the chain, if you will. The more we can see and the more we can know about as things hit the street through distribution, through non-fatals that are shown in the hospital or any treatment in the hospital, anything that is seen, everything is very, as Alex also, everything's very targeted, right? We can only test for what we think or may know about. For us, I hate to, missing things is the worst. We want to know it's there so that we can appropriately react and appropriately, have the knowledge about what's there. So for us, the more we can know about what's out there before it hits us, the better we can actually test and serve to answer what may have caused the actual, pending overdose, at the end.
Sure. Helps frame, the things to look for. That makes sense. Kenan?
I'll echo what Alexandra said as far as the hospital data. I think it would be very useful if we could compare, people's clinical presentations with what drugs they have on board. I think there's tremendous utility for that. And DFS definitely has the capacity to do that analysis. I think a pet project of mine would probably be wastewater analysis. We're doing that a lot for COVID and testing sewage and looking at viral load and really trying to predict those hotspots and comparing that to the numbers. There hasn't been, much funding to do that outside of COVID, but I think we have a big gap when we look at the fire and EMS pickups and the hospital transports. You can't tell me that all of Georgetown is not using drugs. Like, I think there's a lot of drug use that's just not coming to our attention. And as far as, blind spots, I think treatment information is definitely missing from this, especially privately paid for, the Blue Cross Blue Shield and stuff like that. We have access to Medicaid data, but we don't know a lot about drug users who are engaged in private treatment. And I think a missing picture, like Dr. Rosso said, is that intelligence component. A lot of this can be predicted, like what are we seeing in other cities? What connections do we have as far as the drug supply to other cities? Because eventually it will come here. One big thing we've been looking for is stimulants with cocaine and methamphetamine. And, we're constantly looking for that. And the closer it gets, it would be useful if our law enforcement and emergency preparedness / public safety would have regular products that they could disseminate to us for our awareness.
Yeah, if I can echo
Please.
something that Kenan just hit on, which is really important, is the distribution from other cities, right? Especially where we are, a lot of times the distributions in our area, right, are going to come into into the country or wherever it's coming from. A lot of time you're going to see it up north from us, Boston, New York specifically, then into Baltimore, then to us. So, maybe this is an answer outside of our particular group, but those are the type of informations that they're out there. If we see something hitting, the cities up north of us, it's a fair, good information to see that's probably what's going to run down the pipeline, to us here in the district.
Absolutely. And I'll put in a little bit of a plug for our session on Wednesday. We have, it'll be a panel focused on hospital-based harm reduction efforts and highlighting regional expertise from Delaware, Baltimore, and Philadelphia. And I think, that might be a question for that group as well. It's kind of how they use the data and how data are shared between different regions or different cities within a region rather, to lead to action. That's a great point. Kind of sticking with the theme of collaboration, we had a question, I know it's a big one, but how do DFS, OCME, and DC Health work together? How do they overlap? Are there other organizations that can support? You did mention hospitals. I know DBH obviously is really critical in all of this. So maybe if you can speak to like the challenges as well as the facilitators that you think specifically in DC you found with regard to interagency collaboration. Alex, would you like to start with that?
Sure. Yeah. No, we do work together. We're actually part of, I believe, several opioid working groups together that we meet on at least a monthly basis. So there is a lot of collaboration going on. I don't know if anyone else wants to elaborate on that.
Yeah, I think the biggest thing has just been communication. I mean, we've basically built a table and invited everyone on, and there's just that constant communication. And I think these relationships are pretty useful. I mean, I'll give you an anecdote. When we first detected carfentanil in the district, we had 5 people overdose and die in one day. And instead of waiting for the toxicology, the medical examiner called and said there's something going on. And 3 months later, when the toxicology came back, there was carfentanil, and that's what caused it. So I think just those relationships and being in constant communication, going after funding together, sharing our data are probably the best things that we do. But I think privacy is our biggest barrier. I mean, an overdose is not a reportable condition. I mean, it's not the same as if you test positive for a communicable disease or something like that. There are limitations to what I can do with that information. And I think that's probably one of the most frustrating parts of doing this work.
Yeah, I think I would just echo. I mean, as Alex said, the working groups, the dissemination and conversations we have on a fairly regular basis is really important. There's always improvement areas. There's always different ways to collaborate on a more than monthly basis, right? But it really is about the informational flow, from group to group, for sure. Which I think we have a really good basis of, and as Kenan said, I think the informational sharing sometimes is probably the biggest hurdle, and especially for for us it sometimes can be tough, that maybe something is an overdose. It's very hard to for the pathologist to say just because there's drugs on board doesn't mean it gets ruled an overdose, but that is still a data point that goes into the overdose community, right? And the idea of surveilling these types of things. And so it's, it's kind of difficult at times to parse through all of that because it's all part of the big picture. It's all very important, whether it's an overdose death or another type of death, but there was drugs on board, right? It's all kind of, the big picture.
Right, and the messaging is so important, right? There's a degree of data that's helpful, and then there's a degree of data that's just an ocean and can drown out the message. I think that's really key. I know, of course, with DBH's Live Long DC stakeholder summits and engagements, that's been helpful to bring together, I think, a helpful facilitator, obviously, for these conversations. And we've started when we receive at the Hospital Association the it's not an Odmap spike alert, but kind of the overdose alerts. We'll send those out to our hospitals as well. And I see this question that just came in. What is being done to educate health professionals and emergency departments about fentanyl use and the different treatments? I mean, I think some of that when we are receiving those alerts, it's from a care perspective to note that these people might be coming to hospitals, but also for our peer recovery coaches who work at the hospitals to be ready to provide further support for people, not only those who have overdosed, but those who are maybe around it. And there's the degree of trauma involved in that, we know. And in terms of other efforts for educating emergency department personnel to that attendees question, of course, you know, this forum, other webinars, we meet regularly with several of the hospitals who are implementing our hospital-based peer support programs and provide information in those forums. But for our panelists, are there any engagements that, you know, I think all three of you presented some degree of data that comes either from emergency departments or emergency departments are involved in your sources. Do you have any kind of data sharing that you do directly?
I don't think so. I mean, I think we put together, our monthly reports and things that go out on our websites that are pretty much the data that we talk about in our, our summits, as you've mentioned, working with. But I can't think of a direct connection to the ED in those departments.
That might be something we can do. That's a great point, because I think, there's tremendous interest in this, and that maybe we can, send those out to our hospitals as well when to get the data to them more regularly. We had a question: what are your thoughts to have more peer engagement as a solution for this crisis? And perhaps to answer that specifically through the lens of data. Do you work with peers, people with experience of drug use in any way? Perhaps through dissemination?
I think, that's probably one of the most important consumers of the data, people with lived experience who are on the ground making a difference. And I think we probably need to do a better job of getting that data to people in a more timely fashion.
Yeah, I would say I don't know if I know me personally, I don't really, but I would agree that that's an important factor. Knowledge is power in any capacity, right? And you can tell users anything you want, right? Sometimes if you need to see the data, you need to see what's happening, see what they're a part of. So I would agree that dissemination's, a very crucial part of it. As Kenan kind of said earlier, we can put all this data together. Doesn't matter if we don't get it out there to the right people or do anything with it.
Yeah, just to echo off of that, I mean, the closest that we get is to our information goes directly to outreach coordinators from the needle exchange programs. That's some of who receives our report, and some of those outreach coordinators are, peers themselves, and they do share this information with other peers. And I think that's necessary, but we're always looking to add more to our dissemination group, so taking recommendations of like who we should be sending our data to is always helpful, and we're always welcome to that.
Sure. And are there any peers that are part of your organizations that you know of?
Not that I know of.
Yeah, kind of on that dissemination side. Go ahead, Kenan.
We have the rapid peer responders at DC Health, but I think those activities are being transitioned to the Department of Behavioral Health.
Right. All right, thank you. Here's another kind of a policy question, if I may ask you to speak to it. With the quote unquote new Congress, has the district reconsidered pushing for safe injection sites and needle exchange programs? I recognize you're not necessarily the policy people, but any thoughts that you'd like to provide on needle exchange or safe consumption sites?
I know Kenan can jump in. I was just gonna say, if DC were to have safe injection sites, we would be on board with helping validate instruments to chemically analyze drugs that would be at safe injection sites. That is, that is something that we are open to. As far as if DC is doing that, will do that, I don't know.
I mean, that may be years away, to be honest with you. I think it's something our harm reduction community has pushed for quite some time. And we've actually had some high-level visits to other jurisdictions that were doing this, like Vancouver and Washington. I think the compromise we made was the sobering centers where, if MPD or Fems was involved, like that's an option as opposed to taking someone to the hospital. And there is medical attention available there. I mean, it's tricky legally as far as, because drugs are illegal. I mean, getting them there, I mean, is technically illegal. I mean, that would affect, the entire landscape really of drug use in the city. I mean, I don't think we're going to become Portugal or Amsterdam overnight, but I mean, I think this crisis has shown the need for innovation. I think eventually attitudes may soften and things like this will come to the forefront.
Yeah, I think it's a tough topic. I think, you don't on face value, it's good to help those that need it and provide alternative safety to try to help, bring them out of their opioid disorder. There's also, the idea of how do you determine who needs it or versus people who are just coming to get drugs or get high, there's just a lot of variables to take into account, but there's always upsides and downsides, to the different ends. I know from our end, I don't know how much we can contribute per se. I mean, I guess, if there was sites and they were going to make it an actual treatment program, we could do some, preliminary, testings to get baselines for users, which may help in, dosage and, getting that, situated faster. However, that's not, a step one, step two process. There's a lot of variables of that use, but I mean, I think that would be the only kind of contribution we could have, which is, we would obviously be interested in doing. We're happy to help in any ways, but we're a little limited on our end from that capacity, I think.
Certainly. We did have one commenter say awesome when you were talking earlier, Kenan. And I think, Alex, to your point as well, that, there would be a significant opportunity for data as well as, the evidence that discusses the role they can have for people. So yeah, a conversation that we'll keep following. We had kind of pivoting again in another direction. Kenan, you spoke a little bit earlier to when we were discussing kind of the shift in ward surveillance by ward about supply and how that influences, of course, where we see overdoses. Do you know of any efforts to prevent fentanyl and nitazines from entering DC's supply?
Well, I think MPD is on the task, Kevin, and I mean, we have the DEA, we have federal law enforcement agencies as well, but I mean, this is a struggle, I mean, this is really a law enforcement issue. There's nothing any of us in public health can do. I think the most that we can do is try to reduce the demand, but I mean, the supply chain is always going to be out of our hands.
Yep, certainly. Yeah, thanks for speaking to that. Another question that just came in and kind of aligns with one of the last two I had left. Really appreciate the increased surveillance efforts. How can we more rapidly get data back out to the community and or providers to be able to respond more quickly? Kind of like OD spikes, but more for other adulterants. So kind of expanding the methods we've built to other drugs.
I mean, it's possible for other drugs, but I think the issue with that is just, it takes time, it takes time for the toxicology to come back. So that type of, rapid, response, I mean, it's easy to say if someone had naloxone in the field and was revived, you can call that a suspected overdose. But I think for some of these other drugs, it's just, I don't think we'll be able to do that analysis in a timely fashion just based on our current resources.
Yep, I would say hit it on the head. It's just the unfortunate timeline. It takes unfortunately a time to turn a case around, to get that information out for us to know it, and disseminate that out.
Time can be our biggest friend and also our biggest barrier. So that's a good point. We did have one person say maybe we could create an app system. So there's a innovative idea for the future. A question I'm actually I know I'd asked Dr. Rosso, but Alex, do you have any, someone had asked what proportion of overdose deaths are associated with injecting versus pills versus other modes. Did you have data not specifically to overdose deaths, but of just the samples that you analyze in terms of injection versus pills versus other modes?
Sure. So for our seized drugs, we're kind of see everything. We primarily receive powders. Behind that would be pills. So I will say we receive more powders than we do pills in our lab. Again, that depends on what is sent to us. In reality, that could be different, but what we receive is primarily powders. So we assume that people are either injecting those powders or snorting powders. We don't know, but more so than pills.
Thank you. I did just want to add that color to the question. So, all right. So I have one more question that I just want to ask, kind of as we look to frame the next couple of days of our symposium. Day 2 tomorrow will be focused on how hospitals and community are addressing stigma and bias. So we have a panel at 11 that's going to be focused on really actionable ways that hospitals have addressed stigma. Last year we talked a lot about stigma, and this year we want to kind of show what's being done. And then we actually have an artist, William Stair, who has used art to kind of advance anti-stigma work. Day 3, we'll talk about innovative approaches to pain management and substance use disorder patient care at specialty hospitals, as well as that regional expertise in terms of hospital-based harm reduction. So lots of exciting topics. But I wanted to just ask you kind of, we started with data for a reason, and as you know, we've talked about so many different elements and both what we're seeing in DC and nationally. And I think, as we look at stigma in particular, data how do we, as we're going into these next couple of days, how do we avoid, how do we use data smartly? I guess that's the question I want to ask. How do we use data in a smart way as we move into the next couple of days of our discussion? Ken, can I put you on the spot?
Sure. I mean, I think we can use data to get a clear picture. I mean, we've been able to use that. Like, for example, if we had followed the national narrative, we'd be targeting people who had Percocet prescriptions who moved to heroin, but that's not the case. We've always had that problem here. So you want to say how it can target stigma? I mean, I think the goal really is just to raise awareness. And I think it's more useful as far as deployment, where to put resources to respond to the problem. But I think we also have to be careful in how we present neighborhoods. I mean, where there is, enhanced drug activity. And I think we need to be, very, very careful in how we present those disparities so as not to paint those neighborhoods in a negative light or that population.
Yeah, I think it's the data has to be paired, I think, with a discussion, right? It's very difficult to just look at a report or look at a data set. And I mean, everybody could look at it and see it in a different light. So pairing it with a discussion of what it really means and maybe the limitations of things that aren't there due to a limitation that are still, are still factors, things of that nature. So I think the most important thing is to see it, but also have a paired discussion about it instead of just putting it out there and letting everybody think what they, understand it the way they understand it, or choose to understand, I guess maybe is the wrong wording, but the discussion about it, understanding why what is there, why what is not there, because there's a lot of times that things are, we can see and know that maybe aren't in reports per se, because we have, standards and guidelines we have to go to. So the discussion, I think, is the most important part to pair with it.
Yeah, I would say, I mean, exactly as Dr. Razzo and Kenan already said, I think having a discussion is vital. I think using that discussion to pivot towards some action is necessary as well. As far as stigma, that's hard. I think the fortunate thing is that all of us here who work towards public safety, have a deep understanding of opioid use disorder and substance abuse disorder, and we have a deep understanding of that. Whether other people do or not may be the challenge, but I think we are fortunate that the people we work with are compassionate towards people who suffer from this disease. And we do our best efforts to try and prevent overdoses and really just help the public the best way that we can.
And make the table bigger. Well, thank you all so much for your presentations, for your discussion expertise. It's obviously critical framing, as I mentioned, and we are really grateful for your collaboration and partnership, not only with the hospitals, but across the district. So thank you, Alex, Dr. Rasso, and Kenan. Before we close, I have one other, I'm going to share my screen briefly. Just want to end our data day with some of the highlights from our hospital-based peer support system programs that we've been implementing now for over 2 years in 7 hospital emergency department and inpatient units across DC. So cumulatively, if we look at our screening, brief intervention, and referral to treatment programs, which are the heart and soul of that is the more than 20 peer recovery coaches that are employed at our hospitals. We've screened nearly 470,000 patient encounters in 2 years. In February, this was nearly 70% of our encounters in the hospital. And our positive screen rate's 20%. That's an average across all different hospitals, of course. But I think it's important to realize that this is a critical intervention point for people. We screen for the substances listed here, and we did add stimulants this year as well. Our peer recovery coaches have provided almost 21,000 brief interventions in DC since the program started. And we see that that's taken to follow up. So 26% of people cumulatively have been referred to treatment after their brief intervention. That's over 2,300, which has led to over 2,300 individuals linked to treatment that's walking through the door of a treatment center based on the work they did with the peer at the hospital. The other critical component of this program is medication for opioid use disorder. So for patients who are clinically eligible and motivated for treatment, the peer recovery coach during that brief intervention will make a referral to the physician to say that this might be a patient who could be considered for MOUD. In the 2 years we've done this, 61% of those patients referred were actually induced with Suboxone. That's 660 people. And in kind of digging through the root causes of what's the other 40% of people who didn't get induced, we knew and had heard anecdotally that there were a fair amount of people interested in methadone instead. So we started collecting data on that in March of 2021. It's, I guess, been a year now, and have seen 7% of patients referred for MOUD to the physician express interest in methadone. So it's not an insignificant number. And I think kind of that last piece of patients who are either interested in methadone or who do get induced, our peers have referred 97% for that follow-up treatment, and 91% of those have walked in the front door. As we know, of course, the data has shown really careful clinical management of this is really important, and our peers are successful across the board in getting people to follow-up care. And that also helps build trust for our hospital partners that this is something that, whether there's addiction medicine expertise or not, that they feel empowered to start MAT or MOUD because we know that we have such great collaboration with the community and that this is really a group effort. So want to thank all of our hospital partners who are part of this data collection, and of course those throughout the community as well. I will turn it over to Gail to close us out.